Hey everybody, I'm the director of the AEGD at Wichita State University. I want to welcome you here today. We're going to go fast, quick, and have a great time. I'll give a few minutes of an introduction. We have a very diverse audience today, and I want to explain what an AEGD is, where we've been, where we're going, what we do, and the Kansas pipeline for dentists. Before we get into the residents' presentations and our guest speaker, let me give a little overview of the AEGD residency. What is an AEGD? Are the resident students? Who do we aspire to be? Where do our graduates go? Where are we now? Awards and recognition, and where we are going. An AEGD is an advanced education in general dentistry, credited by the American Dental Association nationally. It's a training program with a one-year certificate. It's a dental office, but with 55 certified examinations that happens in our table conferences, our specialty consults, and faculty office. Are the resident students? Yes and no. They are dentists. They have their own license and can practice independently anywhere in the state of Kansas. They choose the technology that Wichita State offers that you will see here shortly. Students have the opportunity to ask for second opinions at any time from the faculty. Who do we aspire to be? This is our team. Any day we have about 18 staff in the building, and we're aspiring to be super dentists. We're aspiring to serve Kansas, especially in areas where specialists are not available. We are compassionate, we are skilled, and we are competent. Our mentors enjoy what they do. Dr. Evans, our senior, one of our senior faculty, leads the mission into Kansas called the Kansas Mission of Mercy. To work with him, it's like being in heaven, both for him and for us. His passion, his desire, his joy of life and dentistry just shines and brings us all up. Dr. Foley's birthday, we had a celebration. He's our endo faculty, our second specialist I've mentioned. He's our endo faculty, and he just loves being with the residents on his shift at Wichita State. Very good about texting with the residents, pre-planning this problem, that problem. So he's available in clinic, but also pretty good after hours. I can't introduce everybody on our team, but I would love to introduce our three leads. Amanda Connor is our program manager. Well, what does she make? I can't explain everything she does, but what she does, which I'll bring into view here, manuals. This is our program manuals. This is her production, her credits, her knowledge, her work. So she's together for structure. The program relies on structure. Second, Machen Johnson's the clinic manager. What does she make? Well, let me grab off stage here. Kaboom. She makes these crowns. She mentors us. She teaches us. Cerac, zirconia. You might say she cooks and bakes zirconia. David May, my lead periodontist and assistant director since the beginning. You will meet him again at the end of the program for his aspirational words. He's always with me, always consulting, always available. Where do our graduates go? At 76 graduates since the beginning. They are residing all over America and Canada. In Kansas, you'll find them in 16 counties in Kansas. These are our clones, the people we've handed off the torch to, sending our message. In the pipeline, two of our staff are looking for a UMKC to go to dental school. Bree Rodriguez on the left, Rosie Pino on the right. We wish them luck, and keep your eye out, dental school. Procedures we completed in 23-24. This is a pie diagram, shows the broad spectrum Doing fillings is 34% of our procedures. It's not beneath us, nor is diagnostic, nor is removable, preventive periodontics, fixed pros, endodontics. It's the perfect pie of what a general practice should be. It's not skewed one way or the other because we do everything from restorative to extractions to educating the patient. Today's presentation, when I talk about education of the patient, it is also a chance for us to practice on the camera our treatment planning and our educational abilities to cast our message. From that, I was given an award. My residents supported us, the team, and I was the Kansas Dental Association of the Year. So for this year, what I'm saying is, the illusion is, it's an illusion. It wasn't me. I received the award, but my team echoed the message of our training, and it reflected back to me as the coach, you might say. In the Wizard of Oz scenario, again, we're from Kansas. I hope you remember that this video is from Kansas. The Wizard of Oz, the Tin Man, represented here by Dr. Shea in the silver. Stage left is Dr. Seabaugh, Dr. Wen in the middle, myself as the professor behind the curtain. The illusion that I'm running the show, but the mechanics is my team. And then to the far right is Dr. Schultes, which you'll all meet today. One award the residency received is for the American Board of General Dentistry for Community Service. The program received this award. Likewise, residents have received the award. Here is Dr. Caleb Murray. Along with this award comes an honorarium for community service. You'll talk about that here in a moment. This would include Sedgwick County Children's Clinic Certificate of Appreciation. This is done after program hours as the residents choose to serve and learn from this rotation. What we say is, what you learn treating children applies to adults. Where are we going? Well, we're expanding to 5 residents. This year was 4, next year is 5. You'll get a chance to meet these amazing young docs today. We will give them knowledge, and soon they'll be back on the stage to share their wisdom. I collect rocks on the Kansas border, a fascination of mine since childhood. This is my display table in my man cave, you might say. Favorite rocks for me to enjoy. Some will become resident gifts. Water is like knowledge in many educational parables. We drink from a fire hose in dental school. We absorb. We overflow with knowledge. We just try to get through the next exam. Too much knowledge, like water, takes time to absorb. During flood times, it's turbulent. Trees are washed up in the bank, and we need time. The residency is the time to be absorbed and to apply concepts and principles. Here we see water cutting into the rock. When water and rock wars, water wins. In a likewise manner, when knowledge wins against us, technology wins. So when water shapes the rock, when water and rock wars, water wins. Knowledge is the same way. It takes time to acquire wisdom.
This is a piece of super floss, and this is something that if you take your acrylic powder, as mentioned in the presentation, and you sprinkle it on a piece of super floss, and then you rub it in. Now take your lighter, like we use to heat thermoplastics. I want you to watch. And we have magic. We have the memento stone, which is our rock. Gold on one side represents the competencies achieved. The other side is non-perfect. It is rough, It is the work we have left to do in our lives. We have been shaped by knowledge. We now have some wisdom with a bit of a ways to go. The whole represents our going forth and giving to mold others the way we have been molded by the faculty.
The rock produced is magical because it's gold on one side, which is representative of what you've accomplished here at AEGD, the 51 competencies. It is a sign of wisdom, of being shaped. The other side is dull. It is rough, it is unpolished, and it's the work you have left to do. It is the work we have, as faculty, have left to do. It shows we are both imperfect, we learn from each other, and we go on to make this beautiful rock that we wear and display. The rock has a natural hole. What does the hole mean? The hole means it is now time for the resident to go forth and give, to be humble, to be kind, compassionate, and be the person they can be, to be as a sign of being shaped, so now they can shape others. I just want to say thanks. Thank you for being here with us tonight online and tuning in. It's 1 hour CE credit through Delta Dental. Join us tonight, for those of you who are local, out at Dr. Carnahan's clubhouse for our 12th annual gathering at his place. I would like to introduce Dr. Morgan Schultes today. She will start with our icebreaker techniques. What I will always remember about her is her ability to combine art and science of dentistry. She will definitely kick it up a notch, as you will see.
My name is Morgan Schultes, and I'm going to be presenting about some perio-pros problems and solutions. A little bit about me is that I went to dental school at the University of Iowa College of Dentistry, and outside of dentistry, I love to do outdoor activities such as climbing into rocks and hiking, hanging out with my dogs, and I also love crafting. And one of the crafts I learned here in Wichita is stained glass, which is that picture down at the bottom. Today we're going to be talking about two different problems that we need to solve. The first being insufficient keratinized gingiva, and the second is bridging tipped implants. So first we'll talk about the insufficient KG. And in this picture, we can see a clear demarcation line between the attached gingiva, the keratinized gingiva, and the mucosa down towards the vestibule. And here's that line showing that divide. We can see here that 2 teeth have sufficient keratinized gingiva, which is 2 millimeters of KG from the cervical area of the tooth or the restoration, and 2 of them do not. Some problems that come up when we have insufficient keratinized gingiva is that the patient will have difficulty keeping the area clean because there will be some discomfort there, and that can lead to gum recession, bone loss, and potentially even peri-implantitis. So we want to avoid that if possible. This case here is very similar to one of the cases that I did here at the AEGD, where we had an implant that was a 2-stage implant. So it was buried underneath the gingiva, and we were going to uncover it. And it's very important when you're uncovering an implant to visualize first where the healing abutment will be. And so that's what this is. We can visualize where that healing abutment will be. And then we need to look to see if there's going to be sufficient keratinized gingiva all around that implant to prevent having that insufficient KG once the restoration is placed. So we can see here on the straight buccal, there is insufficient KG if we imagine where that healing abutment will be. So we need to get ahead of that and do the uncovery process to increase the keratinized gingiva in that space. How we do that is an apically positioned flap. So this is a diagram showing what we will do for this procedure. And this blue line here will show us where we're going to cut for our flap. And then once we do, we will move it more apically. And then we can continue on with the uncovery procedure. We can place the cover screw. We can place the healing abutment, and then the black area will heal via secondary intention. And so once it's all healed, it will look like this, and we will have gained quite a lot of keratinized gingiva on the buccal side of that implant without needing to do a graft. So this is a clinical example of what that diagram just showed. So we can see in figure D is where we did the score for that flap, and then E is we moved it away so we can do the uncovery for that implant. And then in F, you can see that that flap has been positioned more apically, and we gained that keratinized gingiva that was previously over the implant, and then that will heal very nicely with sufficient keratinized gingiva on the buccal surface of that implant. And I would like to thank Dr. Wagle for all the perio consults throughout the year. They've been imperative to our success in this program and our knowledge of perio going forward. The second topic we are going to talk about is bridging tipped implants. However, I think it's really important to go over engaging versus non-engaging abutment parts first. So here we can see these are two different implant cases that I delivered these crowns for at the AEGD this year. And you'll notice here in the x-ray that on the right, there's this darker area within the implant that's not present on the left. And that is a very important concept and difference between engaging and non-engaging abutments that we will talk about soon. So on the right is non-engaging and the left is engaging. And I'd like to thank Dr. Triani for his help reading these x-rays during the delivery appointments and making sure that these implants are fully seated. So here we have two abutments, and on the left is engaging and the right is non-engaging. And we'll talk about what exactly makes them different and how to distinguish between them. The highlighted yellow area here shows where these two abutments will interact with the non-engaging part of both of the implants. And then you can see here, which is the important part, is the abutment on the left has an extension of metal that goes deeper within the implant that engages inside into the internal hex of the implant. And that little tiny piece of metal is the difference between an engaging and non-engaging abutment. So this is a really tiny difference that makes a world of difference when you're restoring them. And so now we can see here, the engaging has that little bit of extra metal, whereas the non-engaging does not. And I would like to thank Kathy for being an amazing assistant. There's a lot of different parts and pieces that go into being a successful dentist, and Kathy is always amazing at keeping me on track and making sure I have everything I need. So now we can go back and talk about bridging tipped implants. So what we would love to see, ideally, is two implants that are completely parallel with each other. If this is the case, then we can use two engaging abutments, and they will be able to fall right into the implants, and there will be no issues. Unfortunately, due to patient anatomy and during the placement of these implants, many times it's impossible to get them completely parallel, and most of the times they're going to have a slight divergence or convergence. So when we're looking at making a bridge for this, if we had used two engaging abutments, just like the previous slide, when we place those, you can see that they're not going to fit all the way and they won't seat completely because of these two interference areas. So the way we avoid that problem is that we use non-engaging abutment pieces. And these non-engaging abutment pieces have a little bit more wiggle room that allow us to still bridge non-parallel implants. So I decided to look into this a little bit more, and this is a research study that looked at 4 different configurations of implant bridges, some with engaging parts and some with non-engaging parts, and we're going to look at them. So what this study did is they made these implant bridges and then put them under stress, and these heat maps show where most of the stress is concentrated, red being the highest concentration of stress. So you can see on the dual engaging piece on the left, there is no red, but on the dual non-engaging, there's red at the neck of the implant. And what that tells us is that if we use non-engaging implant abutments for these implant bridges, is we're going to have a lot more stress placed at the neck of the implant, which could potentially lead to more failures. And now we're going to look at the semi-engaging, where they put the engaging either in the posterior or the anterior. And we can see here it's a very similar concept, where the non-engaging piece creates more of a stress at the neck of the implant, whereas the engaging piece distributes that stress a lot better. Right there. So the conclusions from this study is that the dual engaging would be ideal to use. Unfortunately, there are not very many clinical situations where these dual engaging abutments can be used due to the non-parallel implant placement. but they distribute the stress the most evenly. The dual non-engaging are great when we have implants that are not completely parallel, because they have a little bit more wiggle room and they can still completely seat even if the implants are not parallel. However, they do put more stress at the neck of the implant, so that's something to be aware of as you're restoring these implant bridges. And then both of the semi-engaging, whether the engaging is in the front or back, they are both better because they're kind of like an average of both of those first situations, where they do distribute the stress better at the engaging piece, but they do concentrate the stress more in the non-engaging. And then through their work, they discovered that the semi-engaging with the engagement on the most anterior tooth is the configuration that distributes the stress the best. So our recommendations from these two situations is that always make sure that you're aware of the keratinized gingiva around your implant restorations, as well as your other restorations too, to make sure that you get a satisfactory result. And number 2 is make sure that you're aware of the different abutments that you need to use and can use, and make sure you communicate with your lab what abutments you would like to use for your implant restorations. Thank you.
Next, up to bat is Dr. Leila Sebaugh. What I will always remember about her is her ability to gain wisdom during her stay, and also that infectious laugh as she escorts her patients in the halls. She has streamlined the complex processes of tooth preparation, as you will see.
Hi, my name is Leila Sebaugh, and today I'll be talking about a 30-minute fix preparation. For lineup for what we'll be talking about today, we'll be starting off reviewing the case and then talking about those fix preparations, evaluating the preps themselves, and then the process of cementation. A little bit about me. I'm from Kansas City, Kansas. I love spending time at my parents' family farm in Baldwin City, Kansas. My favorite form of self-care is doing my nails while I watch Project Runway reruns. And my 5-year plan is to end up back in the Kansas City area. And in this picture, I have my dog, Roy. He's clearly a big lug, so I love my dog, Roy. A little bit about the case. So this patient presented originally to the clinic in the top photo with a bridge from 29 to 31. And when I was first seeing her, tooth 29 had already been extracted. So with our plan, we have in that second photo, we have that missing tooth, and we'll be restoring with a bridge, but with only one Pontic. First, with our initial evaluation, we want to make sure we consider our path of draw. This photo here shows that dotted line is going to be the angle of the handpiece we try to maintain, and then the perio probes are there to show the parallel lines between each prep to make sure we're achieving that path of draw that we need for an adequate preparation for the patient. For our 30-minute fixed preparations, what we learned at WSU is a set of burrs that help us get that most efficient prep. So the first one we'll be starting with is the 245C. We know that burr at the cutting edge is about 3 millimeters, so when we use it, we want to start with depth cuts and take it about half the depth of the burr. When we're doing that, we are already knowing that that's about 1.5 millimeters of occlusal reduction. We'll go up the central grooves and the buccolingual cusps, and then we will use that same burr to drop a mesial distal box, just like you would for a class 2 preparation, but in this case, we want to make sure we fully break the interproximal contacts. For our second burr, we'll be using Dr. Elledge's favorite burr here. It's the 240C. It's a great burr for our occlusal reduction. So we hold it horizontal to the occlusal plane, just how I have that picture set up. That'll help reduce the areas that we've established the depth cuts with the previous burr. This way, it helps make it the most efficient process to get that occlusal reduction that we need. For our third burr, it's the 703.8 KRC. This burr is what we'll use to make our margins. So with this burr, we want to create a shoulder, but only in enamel. With that, we want to have minimal strokes. And then once we've created that, we'll switch to our fourth burr, which is the 254S. This burr is going to allow us to remove the lip of that shoulder and create a heavy chamfer. on those buccal and lingual margins. This is going to be critical that we use if we are prepping within dentin. And so sub G, this is going to be the best burr for us to use when we're creating that crown margin. And our fifth and final burr, it's very similar to the previous one, but slightly skinnier. It's the 252 SB burr. This one we'll be using it for the same purpose of removing the lip, but we like to use this one in the interproximal areas so we don't damage the adjacent teeth. Here's our case. So this is that bridge that we will be prepping. When we initially prepped it in the mouth, looked great, but after we evaluated it out of the mouth, this is a 3D printed model, we were able to see we had some undercuts that we needed to address before we gave the final prosthesis. We have the red there to indicate where those undercuts are that we can visualize on the model and that we know we need to address. Here we're doing our evaluation. This is using our surveyor to give us a really great look at where those undercuts are and the extent of them. And again, we have those red areas to show where the undercuts are and the amount of reduction we need to adjust. Here's where we are getting to practice out of the mouth. This is one of the great things we've gotten to do at WSU, is to really have extra help along the way. So we got to practice this to know exactly what adjustments we needed to make before the patient came in. So here we can see how we're holding that burr parallel to the surveyor and where that adjustment needs to be made, which we can see really nicely on the mesial of that tooth. Now for our final preparation, this is what the final result looked like. We can see we've achieved those parallel lines, getting that path of draw that's necessary for the bridge restoration. We have that adequately on the mesial and distal of both the abutments. Again, here is our occlusal view, and no undercuts are present. Now for our bridge delivery, this is a very important step. So we have a nice flow chart here where we'll begin with trying in that bridge, and we want to check for axial binding. How we like to do that at WSU is we line the intaglio of that bridge with our VPS light body material. We let that set, and in that time, it's a great time for the dental assistants to take our pre-cement x-ray. Once we remove that, we're able to see any areas of show-through in the light body. If there are areas of show-through, we can mark those with a sterile pencil and adjust them as necessary. By doing that, that's going to ensure that we don't have anything preventing the crown from fully seating, or in this case, the bridge. Our next step that we'll be doing is checking the crown margins. We want to do that after we verify the axial binding is not an issue, so we can explore that with our instruments and make sure have nice sealed margins. Our next step is going to be checking the proximal contact. This was a particularly interesting new way of evaluating this that I got to learn here this year. We want to evaluate this proximal contacts with using shim stock. So we want to evaluate that and check it and see if that shim stock will drag but not tear. Typically in school, we were taught to evaluate it with floss, but a flossing contact doesn't necessarily mean that contact is closed because the floss is thicker than we would like to see for a contact. If that shim stock doesn't drag and it pulls through a little bit easier than we would like, we switch and go to our paper test. That paper test is going to be checking to see if that paper passes through the contact, we know it's too open. If it does not pass, we're in that happy medium spot of where that that restoration has a nice contact, but and is clinically acceptable, even if it doesn't have that perfect contact with the shim stock. And I have a video to show that in a moment. And our last step we'll be evaluating is the occlusion, which we like to do with green occlusal wax, and we'll talk about that in a minute. Here we have our proximal contact evaluation. We have a video to show how we like to evaluate that. So this is for our bridge. We first check with floss. We're not able to hear it in this instance, but you can see we have what looks like a great flossing contact where it snaps. But again, we want to evaluate it in this different method with the shim stock and paper. With our shim stock, we are looking to see that it drags. In this case, we can see it doesn't have a drag as much as we would like to see. It passes pretty freely. So this is a great time for us to switch and evaluate it with our paper test. This can be any paper. In this case, we're using a Post-it note. And as we're checking it, we can see we are not able to get that paper to pass through the contact. that tells us we have a really great clinically acceptable contact in that area. And lastly, we'll do our occlusal evaluation. This is what I mentioned previously we like to use with our granite occlusal wax. In this case, we don't have major areas of show through, but what we evaluate is to see if any of that restoration is showing through on that granite occlusal wax. The wax is 0.3 millimeters thick, and it's a great tool to use because it simulates food better than a regular articulating paper would. So it helps us visualize how the patient will be using their teeth in a more realistic situation. And in this case, this is our final restoration. I don't have, like I mentioned, I don't have the photos for any show through, but we can see we have a really great final result for the patient that she was very happy with. And lastly, I would just like to thank all of the help I've had in my time at WSU. On this case, especially Dr. Elledge was a huge part in that. This crown preparation method is one that he's taught for years, and I've got to learn a lot from. My fun fact about that is my mom, who's also a dentist, was taught this same protocol from Dr. Elledge back in the day. So it's been really fun to have that generationally passed on. And I would like to thank Mindy Slater as well. She is my dental assistant and is just a huge help to me, and I really appreciate everything that she does. Thank you so much.
Next up is Dr. Hannah Nguyen. What I will always remember about Nguyen is her inquisitive mind and her ability to absorb knowledge like a sponge. She shares great tips today, as you will see.
Hi, my name is Hannah Nguyen, one of the current residents at Wichita State's AEGD program this year. My presentation will be covering a few chairside tips for removable prosthesis. A little bit about me. I graduated from Wichita State University for my bachelor degree. I attended and obtained my dental degree from A.T. Steele, Missouri School of Dentistry and Oral Health. Being back to the Sunflower State and attending the AEGD program has been a great journey this past year. After residency, I will be working for public health clinics in Kansas. We will be going over 2 different cases for the agenda today. There are key concepts that will be highlighted throughout the entire presentation. The first case, we will focus on repairing broken tooth on a denture. My patient came in with a chief complaint of my tooth fell out. She has an important meeting in the afternoon, so sending this to the lab is not an option for us. The first picture shows the tooth having a clean break from the denture base. The second picture shows an air gap as it cannot fit nicely back into place, so we need to create a hole that the tooth can fall back in. And this brings us to the first concept. 2 solid objects cannot occupy the same space, and I will give you some examples. These 2 solid objects can be next to each other, they can be on top of one another, but they cannot both occupy the same space. So let's take a look at my patient's denture. Beautiful denture, suddenly her number 8 fell out. Now there are 2 objects, and we have resins on the denture in yellow and the resins on the tooth in blue are both fighting for the same space. If we want to put them back, one will be in front of another as shown. So what do we do now? We need to create space. The first step is we need to dry fit the pieces back together. We use bi-restoration material to make a lingual matrix for positioning. If not, it will get loose. For the second step, we create a bigger air gap on the denture. So now that we have a bigger space, we use self-curing resins to add the tooth back into place layer by layer. Because we make the space bigger than the tooth, the matrix is useful as a holder as we're filling the resins. After that, we put them in a bath so that it can be cured for a couple minutes. And there we have it. We were able to complete an immediate repair for the patient chair side, and the patient was very happy after. For this next case, we'll be covering different materials that we commonly use here at the residency for removables. A different patient of mine came in saying he broke his teeth on his partial. As we can see in this picture, the partial is worn down and the teeth has broken off. The patient has a severe case of bruxism. We recommended a new partial for him, and our solution was to make a bruxism partial with metal for posterior teeth. The process of making this partial denture is similar to what I have learned in dental school. One big difference is the use of materials for pressure points, and we will be going over a few nominations. As the products being mentioned, we will also give them a rating according to 3 categories. Is it easier, faster, or better? So the classic pressure indicator paste is the first on the list. We use a brush to apply on the dentures, insert it in the patient's mouth, and look for impingements or show-through. We will have PIP as our baseline since it's such a classic product. For the past months, the residents and I have been enjoying using pressure indication spray. It is similar to the paste, but in a spray form. So we spray, insert it, and looked for show-through to make adjustments. With this product, we give 3 thumbs up for being easy to use, faster than the paste, and also show good results. When the denture is not fitting or dropping out, light PVS impression materials is a great choice to use, as it will tell you if it's sitting on the palate nicely or not, better than the paste or the spray mentioned earlier. This product is easy to use and show great results, but we will have to wait for it to set. That's why we did not give it a thumbs up for being faster. The paste or the spray are great for soft tissues. However, when it comes to removable partial with metal components, a better contestant is disclosing wax. So disclosing wax is a thermoplastic wax. We heat up a small amount using a flame, then apply it directly to the metal when it's still soft. Insert it and look for show-through, then we adjust. So remember, apply, insert, adjust. Another key concept here, areas of impingement must be relieved for framework to go into place. Disclosing wax is a great product that we use to locate and track show-through between metal contacting surfaces of partial and teeth. Because of bigger partial, there is more chance of biting. It took some time to get used to it at first, but after a couple times, all the residents and I have been really enjoying using disclosing wax for faster and better adjustments. And this will be the last key concept I would like to highlight. For minor adjustment repair, self-curing resins are a great choice. PIP, spray, or PVS are great for complete dentures with soft tissues. And disclosing wax is recommended for partial denture with metal contacting. Before I end my presentation, I would like to give a big thank you to Dr. Code, Dr. Evans, Dr. Harris, Dr. Marr, and Dr. Robertson for your guidance and wisdom this year. And thank you, Veronica, for being a wonderful assistant. Thank you for listening.
Last on deck is Dr. Alex Shea. What I will always remember about Alex was his technical navigation abilities, but also he had a unique touch for writing. Special thanks for touching up my papers when I needed you. Today, he will share his logic and flow.
Hello, my name is Alex Shea, and today I'm going to get all up in your grill. But before that, just a little bit about me. I attended Grinnell College, where I graduated with a double major in chemistry and theater. And for my dental school, I went to University of Iowa, and I will be returning to Iowa for an endodontics residency after this AEGD. Outside of dentistry, I enjoy the 5 C's. What's that? That would be cycling, ceramics, cooking, cats, and canines. So we'll be talking about 2 different cases today. First one will be number 8 and number 9 crown, and the second case will be number 8 crown with number 9 implant. For this first case, I'll focus mainly on aesthetics and lingual reduction. So the patient presented to me with veneers 7 through 10, but his number 8 veneer had been broken. As you can see in this photo, the piece that he'd been trying to glue back on no longer reapproximated, and he wanted an improvement in aesthetics. I explained to him that replacing just a single crown is one of the most difficult things to do aesthetically, and he ultimately agreed to having both 8 and 9 replaced. Other things to note are the flat incisal edges as well as the missing posteriors, so you know that there's a lot of force applied to those front teeth. We have a prime mill and prime scan at the AEGD, which allows us to do same-day milling and delivery of crowns. And zirconia and tessera, a lithium disilicate, are two of the most common materials we use. For this particular case, I opted for tessera for improved aesthetics. Here are the preps, and you can take note, especially number 9 has a very dark stump shade. And here is the final result. You can see that there is a dark show-through near the gingiva of number 9, but fortunately the patient has a low enough smile line that it blocks the uneven gingiva as well as the darkness showing through. Fortunately, the patient was very happy, but unfortunately, I was not happy to be spending 30 minutes grinding on a new crown. So the issue I ran into pertains to lingual clearance. This is an approximation of my patient's overjet, well into 5 millimeters, if not more. Here's an idealized crown prep, and oftentimes we use a 1.7 millimeter ball burnisher to measure the clearance, and with my patient's large overjet, it was very easy to get that through. Now imagine a crown has been seated. I have the patient biting eccentric and as well as protrusive, and smack! Traumatic occlusion. Patient comes back in a week, crown's broken. So what can you do to avoid this? Enter green occlusal wax, folded into thirds. Here's a piece of it that's been unmarked. Given that I'm using tessera, which has a 1 millimeter minimum thickness, I should expect to see little to no markings on this wax. So place the wax in the path of protrusion, have the patient move forward, and in my case, had I done this, you'd see that the lower anteriors have dug into the wax, and if you held it up to the light, you can see show through. With this information, I should have reduced the lingual further, placed the wax back, have the patient move forward, and you'd see very minimal indentations, and when held up to light, virtually no show through. With this new crown, I'd have the patient move forward, and voila, no traumatic occlusion. So a couple takeaways from this case. To address a dark stump, you can use composite to block the darkness, or you could use a more opaque restorative material. Also understand the patient's etiology. Why are you fixing the problem? So if this patient presented with a broken veneer, very possibly it was due to traumatic protrusive forces. So that leads into the last point. Lingual clearance must be measured in protrusion, not just eccentric. So using the wax, we want to see the one on the left, not the one on the right. I'll be moving on to the second case here with the number 8 crown with the number 9 implant, specifically talking about gaining kg, fabricating a temporary implant crown, and gingivectomy. Patient presented to me with number 9 implant already placed, and when looking at the implant and visualizing where the abutment would be, I realized that there would not be enough keratinized gingiva around the implant, so opted for a graft. A graft would also benefit number 8 because, as you can see, it also has barely enough keratinized gingiva. Dr. Schultes talked about an apically positioned flap to gain kg, but we determined that doing so in this case may not yield the most optimal aesthetic result. So we went with a split thickness graft. So I made a split thickness incision at the recipient site, as well as a split thickness piece from the donor site, and then I grafted it onto the recipient site. with several sutures. And a big thank you to Dr. Wagle for assisting with this procedure. 2 weeks later, we see that there's already great healing at both sites. And 1 month later, even better healing. At this point, we are ready to uncover the implant. Because we now have adequate KG due to the graft procedure, we opted for a tissue punch and a curettage burr to expose the implant. And once the healing abutment was placed, we delivered in Essex. And a huge thank you to Tanya for dealing with my incessant need to take photos and for doing a lot of great lab work. Next, we're ready to temporize the implant using a temporary snap abutment. In addition to that, we use a prefabricated crown. We drill a hole in the lingual until we are able to position it in our desired emergence. Then we take that snap abutment, place it on the universal analog holder so we can easily manipulate it, and then we trim it and place it back intraorally to make sure that it won't stick out through the prefab crown. As Dr. Nguyen showed, we use a lingual matrix to hold the crown in our desired position. And then once placed intraorally, you can visualize the snap abutment through the lingual opening. From there, we take flowable composite to bond the two pieces together so that we can manipulate the two pieces as one. We then put this back on the universal analog holder and then add flowable composite to the cervical portion of the temp crown until we have the exact contour. You can see here that the temporary crown is not the exact shape and color as the adjacent tooth, but the most important part of temporizing here is to develop the soft tissue contouring. And while we have the capability of performing same-day crowns, we decided to temporize to see if we needed to perform a gingivectomy. And when the patient returned 2 weeks later, indeed, the tissue had rebounded, and we could see that the zeniths were not symmetrical and not to the patient's liking. So what can we do? Gingivectomy. A huge thank you to Dr. May for helping with this procedure. And now you can see that the zeniths are even. Once we were happy with the temporary phase, we were ready to move on to the final restorations. You can see that the tissue has formed very nicely around that temporary crown. Using a scan body, we scanned both number 8 and 9, and you can see on the scan that now the gingival zeniths are quite symmetrical. A huge thank you to Machen, who has helped us immensely with digital dentistry workflows, as well as troubleshooting tech issues. So this is what the patient had before, and this is the final result. Huge thank you to Modern Methods Labs for fabricating these two crowns. Patient was extremely happy with the result and is excited to come back to get more of her dental work done. And that's it. Thank you all very much for your time. I've really appreciated this year here in Wichita, and while I'm excited to be going back to Iowa for further training, I'm very sad to be leaving a bunch of friends and colleagues.
It is a tradition to give gifts to acknowledge our faculty. Today, I give a gift for our lead periodontist and team member and senior dentist, Dr. David May. Dave, please join me to receive a gift from your team. And he's a periodontist, so we have him a gift, and it's marked 369. Us in the business knows what that means. What you learn at AEGD is if you got a molar with the 6, he's our man. So, to continue on, this is the gift we've made for you, Dr. May. And I have to uncover it with our special magical scarf. And what we have here is a shepherding staff, because you are the shepherd. You teach us to be humble, you teach us to be hungry. You brought me on my first mission to Kansas 10 years ago. So what we have is signed by the team that supports you at the bottom. handle for you to grip firmly as you lead us. Also, we have the current residents have signed each bear paw of the bear, since you are the Papa Bear. Always have been to all of us. You are my lead, and you also always have my blinders in my rear view mirror. So that being said, each resident has signed the current class. Also, we have blank spots. Blank spots are bear prints, work you have left to do. This year we'll add 5 more to the program, 5 more signatures as you make your way to the top, Papa Bear. Thank you very much.
Thank you.
Man hug.
Thank you, Dean.
All right.
Thank you so much.
I think you would like to say a few words?
Sure.
Okay.
I'd love to.
Dr. David May.
Throughout my professional career, I've grown to appreciate the importance of graduate level dental education. And one of the greatest joys of my life is witnessing the growth, the professional growth of these young people in the short 12 months that we're with them. And it has been a joy to serve and teach in this program, and it has made me who I am, and it's a blessing to be able to be part of our residency program at Wichita State. So Dr. Elledge, thank you very much. This is a treasure for me, and I really appreciate it.
Hey, I'd just like to wrap it up as we head towards the end. We've had an amazing presentation today, and what's equally exciting is the 5 young doctors you're going to meet today that are going to put together their story for their chapter for next year.
Hello, my name is Claire Freeman. I am from Olathe, Kansas, and I just graduated from UMKC School of Dentistry. I'm really looking forward to the next year, just learning some more advanced restorative techniques and growing as a clinician here in Wichita. After I finish up the program, I'm hoping to stay in Kansas and work in private practice as a general dentist.
Hello, my name is Dr. Bradley Miller. I'm from Niles, Michigan, and attended the University of Michigan School of Dentistry for dental school. This next year, I'm really looking forward to enjoying our nice facilities that we have, working with our tremendous faculty, and just really improving my clinical expertise from where it was before starting this residency. After the residency, I'm looking forward to going into private practice with the hope of owning my own practice in the very near future.
Hello, my name is Nick Desch. I'm from Topeka, Kansas, and I graduated from the UMKC School of Dentistry. I'm looking forward to meeting my new patients here as I will be staying here in town for the rest of my career, and I'm looking forward to many of the new techniques that we'll be learning here in the program.
Hi, my name is Emma King. I'm from the West Michigan area. I graduated undergrad and dental school from the University of Michigan. Go Blue! I was looking for a program that had great culture and allowed the opportunity to continue education specifically in implantology and endodontics. I loved the culture that WSU had to offer. My mom was born and raised in the Wichita area, so I was excited to get to experience the place that she spoke so fondly of. I'm here with my husband and our 2 dogs, and we're excited to explore the Wichita area more. We've already really enjoyed what we've seen. Looking to find a community, hopefully in the greater Wichita area after completing the program.
I'm Elizabeth Kiepner. I am from Cape Girardeau, a town in southeast Missouri. I attended the University of Missouri-Columbia for my undergraduate studies and the University of Missouri-Kansas City for dental school. I'm excited for this AEGD program to further my skills in surgery and implants while still under the guidance and mentorship of faculty members. And after graduation, I plan to join a private practice as an associate. And as for this year, I'm very excited to join a great team and serve the citizens of Wichita.
Well, hey everyone, thanks for joining us for an hour of CE. Hope you picked up maybe a tip or two. Click on the link below to get your credit. Thank you.